Now we will move to a very important session, which is the UK experience in trauma. And we have many eminent speakers from UK. Our first speaker will be my dear friend, Dr. Zohair Nawaz from Brimley Park Hospital. Dr. Nawaz, how are you, sir?
Good, thank you. Thank you very
I'm
much.
very happy to see you again, sir.
Hi, how are you?
How are you? Thank you so much. Professor Nawaz will speak about fixation principles.
Okay. Bear with me. I'm hoping you can all see my screen.
Yes, sir.
Perfect. Okay. All right. Welcome, everyone. We're going to speak to you about fracture fixation today. So it's the start of the session. I've given this talk in different varied forms before, but it always seems to be well received. And the most important thing really is that failures are just as instructive as cases that we do really well. And that was a famous quote from one of the ex-president's wives. So this is a classic case that came in my clinic that needed managing. This is obviously a fracture that was managed elsewhere, and the fracture fixation has failed. So this is a regular case that I present because it has so many issues that people need to understand and explain in their mind how they go ahead with that fixation. So we're going to start with just simple basic fixation principles. So there are always different modes of fixation. We've all done AO principles and we understand what those principles are. But the one that most people find difficult to understand is bridging fixation, which is classically the distal femur. So we always talk about the fracture and how we get it to heal. So we talk about the fracture personality, the soft tissues themselves. When we fix it, getting the alignment, we talk about the host and we talk about the metalwork. So the fracture personality is really important, looking at the type of fracture, whether it's comminuted, whether it's high energy, which part of the bone involves, whether it's diaphyseal or metaphyseal is really important. The soft tissue envelope, we all know, is incredibly important. The alignment when we fix it with the appropriate metalwork is really important. And the host, unfortunately, in a trauma situation is very rarely we can do anything about it, except for the fact that the patient is the way they are, whether they're diabetic, on steroids, etc. So the reason this lecture's first is to just start with some basic principles, and my colleagues will then go on to talk about other issues with trauma and their cases. But essentially, these are the three main laws that people talk about. So we talk about Wolff's Law and we talk about Perrin strain theory. These are the two main laws, really. So Wolff's Law is physiological response to normal bone is dependent on the mechanical environment. And Perrin strain theory also has a similar theory, which is the strain will lead to a physiological response to the broken bone. And that's again affected by the mechanical environment. So these two laws and the Frost concept all basically say, however you manage the bone, the mechanical environment you put the bone after you fixed it will determine how the bone heals. And that's the most important thing. So the bit from our point of view as orthopedic surgeons is how do we fix the bone appropriately so it heals? So this concept has been thrown around as now well established, and we call this the bone healing organ. So the hematoma that forms after the fracture is critical. And managing that hematoma, managing that area where the injury has happened is paramount for the fracture to heal. So that's why we realize that non-open fractures are less likely to heal well and are more likely to go into non-union. That hematoma that forms at the fracture is sitting on the roadside or is sitting outside the body. It's no longer there. And then you debride and you open up the soft tissues, and therefore that bone healing organ is significantly damaged. And one of the things that we know is that the strain environment is one of the most important things in aiding the bone healing organ, i.e. getting the fracture to heal. It's really important. The strain is the most important thing here. So I'm just going to go through some basic concepts. So we're going to talk about load bearing versus load sharing. So load bearing essentially means that when you put a plate onto a bone, some of the weight is going through the bone and some of the weight is going through the plate. Now that is dependent on the fracture pattern. So the first two scenarios you can see that we've got a straight transverse fracture we've used a compression mode, most likely, and the majority of the load is going through the bone, and the plate is doing very little. In the second scenario, we've got an axially unstable fracture. So we've got an oblique line. And so therefore the bone is trying to shear off. And therefore the plate is having to work harder to hold the fracture together. And in this scenario, once again, we have bone load sharing. So some of the bone taking the load, but the plate taking more of the load. In a scenario where we have a defect or we have comminution and we've got a gap, essentially the bone is not in continuity, are not in contact, at that point, the plate is taking all the load. And in that scenario, we talk about a load-bearing construct. So that first X-ray I showed you, where we had a comminuted section of femur spanned across, that plate is completely load-bearing. So none of the load is going through the plate. Through the bone. So the question for us is, when we're trying to fix a bone, we want to decide how we're going to fix that bone and how much force we're going to put through the bone and how much we want to put through the plate. And depending on those forces will determine how we fix that fracture. So that determinant will then decide how the bone's going to heal. Is it going to be absolute or relative stability? Have we got perfect anatomical reduction? Have we lagged across the fracture? Have we done an indirect reduction? Have we restored the angular and rotation deformity? And what type of implant have we used? These will all determine how the bone essentially heals. And therefore, each device will require a different method. So if you're using an IM rod, or if you're using a bridging plate or using an X-Fix plate, then the stability and what you need to achieve to get the fracture heal are very different. So strain is the most important thing here. So strain is what we call change in length, is length over changing length. So therefore, from our point of view, what we're trying to do is make sure that the movement of the fracture site is sufficient enough for bone healing to occur, whereas not so much that we get a non-union or we get a fibrous union. So these are the points that we talk about: A, B, and C. So A is where we have such a rigid fixation, there is no bone formation. So that's typically where we talk about putting too many screws into a plate. We make it so stiff, and therefore the bone doesn't move, and therefore there is no healing response at all. Whereas we get to the other end, where we get to level C, where we have so much movement that we've essentially got a non-union or we've got fibrous union, because the bone ends are so mobile, there's so much movement in the fracture site, no healing can occur, and you get that classical significant amount of callus but very little healing. So you want this ideal scenario, which is around the point of B, which is about 2% of strain, so that's 2% change in length, where essentially there's enough movement for the bone to heal, whereas so the bone will then start to regenerate and we'll get our classic callus formation and healing. So this is it zoomed in, so you can see, I don't know if you can see my arrow, but this is the point at 2%, where we have a point where essentially it goes from too much stiffness to just about enough where Wolff's law starts to apply and the bone starts to heal. Okay, and in that process, we all talk about relative stability, absolute stability. But the key here is trying to get that stiffness just in the right position so that we get that healing process going. So how can we get that strain in the right position? So we talked about these before. So we talked about fracture personality. So it's understanding the fracture itself. Is it just a simple, straightforward fracture? Is it an open fracture? Is it comminuted? Is it segmental? These are really important. What's the soft tissue like? Obviously, if it's high energy, it has significant periosteal stripping, then from our point of view, what we're looking at is trying to minimize further damage to the area, the metal device that we're going to use to fix the fracture, and then to try and get it aligned as best as we can. So in this scenario, again, we look at this and we look at this plate. So this is what we call a dynamic condylar screw plate. If you've not seen this, this is a non-locking device with a screw at the bottom that is spanning a segmental fracture. So this is a load sharing device. So some of the load is going through the plate and some of it's going through the bone, because these non-locking screws mean that the plate and the screws are moving, and therefore you don't have a rigid construct. So Some people would say this is a bridging concept, and what we're going to do is now discuss that. So this is what we call by bridging mode. So a bridging mode is an internal X-fix. We all have heard that term. So it's like putting an external fixator on with pins. So each screw is a pin, and those pins are fixed to the plate with the locking threads. Now, from our perspective, each one of these scenarios, the plate has been put on in exactly the same way, but the strain environment for each of these fractures is significantly different, i.e. the amount of force going across the plate. So you can imagine the force or the movement in the first fracture compared to the fourth fracture are significantly different, because there is far more movement in the fracture number 4 because the bone is comminuted and segmented versus a straight transverse fracture. So in this scenario, as a surgeon, we have to accept that we can't just simply make the bone look straight. We've also got to realize that if we do the same construct for fracture 1 and fracture 4, there is a chance that fracture number 1 will go into non-union because there's so little movement within that construct. And with fracture number 4, we need to accept that there is a lot more movement in that plate and in that fracture, and therefore we may need to put some extra screws in to bring that strain environment down so we get healing. So the bridging concept is really important. So this is the idea that the load goes through the screw, through the bone, through the screw, across the plate, then back through the screw and back out, exactly like an X-fix. This can only really be achieved with a non-locking plate. With a locking plate. If you have a non-locking plate, that is in effect the same as an external fixator, but loosening the nuts around the pins. In effect, you have a loose external fixator. At that point, the pins are moving, the bar is moving, and therefore the bone will load, and therefore you're more likely to get a higher strain environment and more likely to get a non-union or fibrous union. Whereas with the locking plate, the idea being because it locks in, we're trying to tighten these grub nuts around the external fixator bar, which gives us a stability. So when we walk or take load through the bone, it goes through the screws, along the plate, and then back down and bypasses the fracture, just like a bridge. So actually, there's a difference. So this plate is a non-locking plate across a wrist. So this is in spanning mode. And here on the left, we've got a diagrammatic picture of a locking plate in bridging mode. So we can see that the forces going through this plate go through the screws, through the plate, bypass the fracture, and then back up. So the movement generated at the fracture site is not of the fracture itself moving because we've created such a rigid structure, but the movement of the plate. The plate is what's generating the movement. As we load, the plate will bend or have a bit of micromotion. In a spanning plate, we've got the fracture moving, we've got the bone moving, and we've got a relatively non-rigid plate. And so there's forces going through the bone and the plate at the same time. So this is shared forces across the fracture. So this is where we talk about a non-locking plate being not length stable. So when you axially load a plate, the non-locking screws are likely to pull out sequentially, and there is movement between the screw head and the holes in the plate. Whereas in a non-locking plate, in a locking plate, those screws are engaged into the plate, and therefore for the plate to fail or for the fracture to load, all screws have to fail, which is why a non-locking plate is not axially stable, i.e. if you load it, you will load the bone. The other part of it is the working length. So how much of the plate is doing the work? So I've again got 2 diagrams here. So you can put lots of screws very close to the fracture, or you can put the screws further apart, and we've got a part of the plate that's doing the work. Obviously, the more the forces across that plate, the more the movement there is and the more the strain there is. So if you've got a very comminuted fracture, ideally you want to put the screws closer to the fracture to reduce the strain environment, whilst making sure that your working length is appropriate. You do not want too stiff a construct. Whereas if you have a very straightforward transverse fracture, you actually want the screws to go further apart because you want a longer working length. You want that plate to do a bit more bending, because if you put those screws too close to that fracture, they'll be too stiff and you'll get a non-union. So again, it's that experience that comes with understanding what the strain environment is, where to put those screws to achieve that strain environment. This is the final thing. Again, it's a very similar concept. We talk about the X-fixes. So it is important always to try and span the whole bone. If we look at X-fix constructs, I've got two constructs here, one on the left and one in the middle. And you can see that if you space the pins out, high up in the tibia, wide apart, low down in the tibia, wide apart, that is a much more stable construct mechanically than having two pins very close together, like in the middle picture, with a short bar. The longer the plate, the more stability it provides to the entire bone and the better the working length of the plate. Okay, so again, that's why when we start talking about periprosthetic fractures, the majority of us will always say that the best thing to do is to span the entire bone from top to bottom, and that provides this construct on the left. Locking screws into the locking plate, far apart, allows to share the strain, share the movement, share the load through a longer bit of metal, which will obviously help with your strain environment. So the last thing to mention is fatigue failure. So every plate will eventually fail. So that's cyclical loading. So in fractures, we have a race between healing and the plate failing. And therefore, there will come a point where the plate eventually fails. In this scenario, what we're trying to do is to reduce the amount of load going through the plate so that we get as many cycles as possible. So this is a classic example of what we call an SN curve. This is where we talk about the number of cycles and we talk about the load being put through it. So on your y-axis, we have stress, and on the x-axis, we have number of cycles. So if we look at that first picture that I showed you of the femur, where the plate was in spanning mode, non-locking mode, the amount of force going through that plate is significant. Therefore, we're at this point here, well above the first little star. We have a significant amount of load going through the plate, and therefore the number of cycles we can achieve is not many. Okay, whereas if we look at the big star and we can reduce the amount of force going across the plate, and we're in that zone where the big star is, then actually the number of cycles we've got for that plate to survive before it fails is more. So the idea of moving the amount of stress across the plate down to from the little star to the big star is to get more cycles and therefore giving our bone more time to heal. So we want a lower stress across the plate. So therefore, we're as close to the endurance limits, we get number of cycles as well. The last thing to mention, is off-axis fixation. So we all know, we've all used the DHS. So the DHS is a great simple device which works really well for an intratrochanteric fracture. But the idea is that it's got a lever arm, which is why we don't use DHSs normally in a subtrochanteric fracture, because in a subtrochanteric fracture, the fracture forces are not in line with the DHS screw, but they're a rotational force. So as you load, the proximal femur wants to go to varus, and therefore you've got a pivot point. So you've got a lever arm, and you want to try and reduce that lever arm, which is why we say you need to put a nail down a subtrochanteric fracture, ideally, because you shorten that lever arm. The nail is within the intramedullary bone rather than on the lateral aspect, and therefore it's better at resisting rotation. That's exactly the same with plating the femur. If we look at the mechanical axis of a femur, typically it's, ignore the one on the right, on the left, but on the right, the typical mechanical axis goes through the center of the knee or slightly through the medial compartment. Therefore, actually, the best place biomechanically to put a plate on a femur is medially, but obviously we can't do that due to the neurovascular structures, and therefore the plate typically ends up on the lateral side, which means it's now an off-axis fixation. It's not on the weight-bearing axis of the bone. So that's why the plate starts to bend, because we're loading it off-axis. That's why the screws are so important, to allow us to position those forces and allow us that bone to heal. So in summary, when we're looking at bridging mode, it's really important to think about the strain environment, what mode of fixation you're using, consider your working length, always think about on-axis fixation if you can. So in the femur, that's obviously difficult on the medial side. However, if you have a very medial side, if you have a very comminuted fracture, always consider potentially putting on a double plate. So you'll see lots of papers now about plating the medial side. That adds further fixation. And then always think about your stress strain curve and cycles to failure. Thank you very much.
Thank you so much, Dr. Zohair Nawaz, for this very interesting talk about fixation principles. Thank you so much, and hoping to see you again in CCOT, sir.
Okay.
Thank you so much, sir. Thank you so much,
Bye,
sir.
Professor.
Thank you, sir. If we have any questions to Professor Nawaz? I think you have mentioned all the aspects regarding the fixation principles, sir. It was a very comprehensive presentation, sir. Thank you so much. Our next speaker will be Dr. Azal Jalungar. He will speak about dual plate nail fixation for distal femur fracture. Dr. Azal, thank you so much for being with us, sir.
Good evening, Prof. Can you hear me?
Yes, sir. I can hear you.
And you can see me, Prof?
Yes, sir.
Perfect. Congratulations. You're holding a fantastic talk. I mean,
thank you so
wide
much.
variety of speakers, good talks. And I admire your endurance because you're going on for another
so
3-4 hours.
For 12 hours, sir.
Yes, absolutely. I'm just going to try to share my screen and see if that works. Share screen, share. Can you see my screen now?
It's yes, we can see it now. Yes, sir.
Perfect. So I'm gonna carry on after Mr. Nawaz. We worked together, we're great colleagues, and it was a very comprehensive talk about types of fixation, types of healing, stress strain theory, modes of fixation, and how our plate fixations fail and how to get it right. So I'm not going to go into details about how to do things and what is the theory behind it, but we're just going to probably look at some few cases, interesting cases, to see there are different ways of managing it. So I work in Frimley and a few more hospitals. Frimley is a big trauma center, and when we get something small to very complex injuries. So I'm going to talk basically about femoral and distal femoral complex fractures. We know these are difficult fractures to sort out because more, especially in the UK, they are seen in more elderly population who've got very weak osteoporotic bones, and treating these surgically is quite a big challenge, purely because of the high morbidity and mortality associated with these cases. And we all agree, I don't think there's any debate whether we need to fix this early, because this definitely reduces the morbidity and the mortality and gives us a chance to get the patients moving early, and in turn reduce complications and aid the fracture and healing. Now, what we need to do recognize is these are complex fracture patterns. So these are not for the faint-hearted to go and venture into. So these do require some advanced skills. And if you're just getting into a consultant post and we're all very enthusiastic to fix them, I would suggest obviously try to get these done as dual consultant case with your senior colleagues. And the more experience you get, the better you get at planning these and managing these. So all that done, let's look at a few cases. Now, straight away, you can see from the x-ray, this patient's got a below knee amputation. 88-year-old, and this is not elderly here. An 88-year-old is male, poorly controlled type 1 diabetic, fell down and had this fracture of the distal femur. He uses a prosthetic walk, so he's a walker. So obviously we got the diabetes under control first before we decided to do anything. So now looking at the x-rays, you can clearly see it's a smashed up distal femur, a lot of comminution, not enough tibia, just a small part of tibia left. Now, one could argue you could leave this and see if we can get it better and see if we can get if it heals. But I think it doesn't, you don't need to be rocket scientist to say this is a difficult fracture and it's probably not going to heal. And if it does, it's probably going to take a very long time and not heal in the right position. So we need to do something about it. Now, one could argue that we could plate it, nail it, do all sorts of things. But that's where planning comes into action. Definitely get a CT scan of these distal femoral fractures, proximal tibial fractures, because it helps you, one, to decide what type of treatment, where your approach is going to be, how your soft tissue envelope is, and what's the best construct that you can go through. You can clearly see the distal femur has now buttonhole through the quadriceps. The lateral condyle is split. So fixing this with a plate, 1 or 2, will be difficult. Secondly, he's a below knee amputee, so you want to get this going as soon as possible. Can I fix it with a nail? I doubt it, because it's so distal that the distal screws will not hold it. Now, what are the general considerations looking at this case? He's an amputee, he's diabetic, very distal fracture to nail or plate in isolation. We've discussed this. The quads are torn, the fracture is buttonhole through it, very poor bone quality. So ideally, yes, in an ideal world, we'll try to plate it both laterally and medially, as Mr. Nawaz suggested, best constructed from the medial side, but very poor control. I don't want to put him go through two wounds and 2 plates, or at least 2 big plates. So I want to reduce the risks of infection. One could say, yeah, you could link the plate with a conventional intermedullary rod, but this would be a struggle and the result would be unpredictable. These fractures, the problem with these fractures are they often go into varus. So we need to take that into consideration to plan it, whether we can put a medial plate or intermedullary construct. So as we always do, we do an MDT of these complex difficult fractures, and then come with a plan, and always have more than one plan in your book. I'm not here to teach all you accomplished surgeons, experienced surgeons, how to skin a cat. There are different ways of skinning a cat. This is just my experience. The one thing I would suggest is always have a plan ABC and have an MDT discussion with all the colleagues. So what we did, we put this gentleman on the table, obviously, tried to reduce the fracture, difficult and not unpredictable. It was very predictable. It will be difficult to get back to length. It was about 2 or 3 centimeters short. So what I used is a distal femoral distractor. So you can clearly see the shank spins going through the distal femur and the proximal tibia. And with the distractor, we got it nicely in place. We got the fracture reduced, back to length, varus valgus angle corrected. The next step for slide number 4, the image number 4, you can see, I wanted to temporarily stabilize it with something. So you can see the guide wire, sorry, a K-wire, and a posterolateral. It's a posterolateral anti-glide plate. It's a 1/3 tubular plate as an anti-glide to temporarily hold the fracture. You can see I've got 1 screw holding on there and probably another screw going distally, but I've planned it such that I'm gonna probably have to move that screw or change that screw later, but at least I'm temporarily fixing it with the anti-glide plate, and then use a guide wire, an intermedullary guide wire, to do a fibular strut graft. So use a guide wire, just ream over it, depending on the size of your graft, and then you get a nice fibular strut graft into as an intermedullary device in there without having any metal as an intermedullary device. Okay, now I'll tell you why fibular graft over an IM nail. 1, I already want to reduce the number of amount of metalwork in the knee. 2, it's a good graft. So if I want to put some distal screws, I know my screws are going to go through some good cortical bone through the graft. Now, if you slide on top, you can see the top left, we've got some graft in. You can see my proximal screw is stropping the graft. So I've changed that to 2 small screws, got the graft right up all the way across, and then Bob's my uncle. It's easy. Get the plate size measured, the length measured. You got a ruler there, measure the side of plate, and doesn't matter what type of locking plate you use. This is a DePuy Synthes locking plate, VA locking plate. Important, as Mr. Nawaz says, get locking screws in. So you can see the distal screws are all locking screws. You got a posterolateral buttress plate. You got a fibular strut graft in, and then you get some nice proximal locking screws across the fracture. These are intraoperative pictures, and we look at the post-operative pictures. So quickly going through it, it was a lateral subvastus approach. It was short and difficult due to the amputation, poor bone quality. Used a distractor. It reduced the fracture. Put a 1/3 tubular plate, and then use a midline patella tendon approach to put the fibular graft in, and then lock it with a lateral femoral plate. Important. These are big wounds. If you think healing will be skin infection or ooze or whatever is going to be a problem, I always recommend use a negative pressure vacuum dressing, a Pico dressing, especially if with my complex fractures and my revisions. I've put this as a norm, and it's definitely improved healing, and I've had less problems with oozing wounds. This is an intraoperative picture of the spanning the fixator. You can see the position, below knee amputee. Forget about the other one. I'm talking about the left side. There's a distractor, small proximal incision for the other plates, the other screws. These are the immediate post-op X-rays. Looks all right. There's a bit of a gap on the medial side. Not to worry. As long as you've got it nicely reduced, stabilized with a good fixing principles, it'll heal. And there are 6 months post-op. Patient's very happy. Back, we had to change his prosthesis, of course, because of the size of the plate. It's a bit thick, but that's fine. We got a new prosthesis in, and he's happy mobilizing, a below knee amputee. And he's now 90 years, a happy 90-year-old man. That's my first case. Now, second case, very similar. Again, 90-year-old, very young, but a few comorbidities. She's got cardiac failure. She's got some heart problems going on. She's on blood thinners. But this is even more distal fracture. It's an intra-articular smashed up fracture with loads of comminution. Now, obviously, this is even trickier to fix. I don't think a nail plate combination would work in this because of the distal nature and the intra-articular nature. And look at the osteoporotic bone. I mean, the bone is like butter. You don't even have to use a drill to put a screw. So all this in mind, we could spend hours trying to fix it and make our X-rays look good. But I always say, keep the patient in mind, not just the fracture, the whole patient. You want an effective, reasonably quick surgery to give the best outcome. Not a surgery which is going to take you 8 hours and your X-rays look good and the patient dies. So again, planning is important, which is why we get a scan and you can see both sides are off, both condyles are off, intra-articular split, and displays fracture. Now, the good thing for her was she was an independently mobile lady. So I wanted to get her mobile as soon as possible. Now, if I plated or nailed or plated and nailed, it would be, I'm sure we all agree that this would most likely fail. And we will end up having a second surgery or third surgery. So this is where we decided, let's give her distal femoral replacement. Now, it's I wouldn't say much easier surgery, but it's a more predictable surgery if you plan it properly, where we decide what's the length of the fragment, length of the fracture, well, length of the distal fragment you need to remove, and then just do a revision type of a tibia and do a distal femoral replacement. Now, a few considerations is, of course, pre-op templating, absolutely vital. That's when you get the height right, the rotation right. That's when you know that we're not going to make the knee too lax or too tight. Key is to reduce the fracture fragments first. So I know these are difficult fractures, but try to cobble them up together just to get the height of your osteotomy right. And obviously, once you get the height right, which is normally measured from the medial femoral condyle, we then mark at the top end where the osteotomy is. We just make a midline mark to guide our rotation. We need to get the rotation of the distal femoral replacement right. Put a prophylactic cable on before reaming, especially with these osteoporotic bones, because you will propagate the fracture if you don't put a cable at the top. Now, it's very easy. The posterior neurovascular bundle is very close. Now imagine if you made an osteotomy of the distal femur with sharp edges and we're nicely reaming it without considering that there are some pumping pipelines behind the fracture, there's a very high chance that your fracture itself will cut through the bundle. So I always say, use a bone hook or whatever you have and a strong assistant so that he or she can lift the femur off, and you interpose the distal sharp end of the femur with any protective thing you have, either gauze or swab, whatever, so that it doesn't puncture the neurovascular bundle. Then the tibia is prepared like any attuned revision tibia with stem and sleeves. Again, templating is important. You want to know what the size of the stem and your sleeve is going to be. And the femur, again, there are various sizes. We won't go into details, but what we use is the DePuy LPS system, which gives us good options, starting from extra small to whatever size we want. And it's got 3 components. It's got a stem, which can be either cemented or uncemented, that goes into the femoral shaft. The length, again, you can determine what you want. It's got a segmental component, which gives you the height you want. It starts at around, I think 25 millimeters and goes up to 250 millimeters. And then there's a distal femoral replacement component, which goes from extra small to any size you want. So always, whenever you're doing these replacements, these complex endoprosthetic replacements, you have to consider the soft tissue envelope to guide your size. Now, what you don't want to put as a big distal femoral replacement in a tiny lady and then struggle to close the wound and have a very tight soft tissue envelope. So that's the key. Always consider soft tissue, no matter what type of surgery you're doing. It could be a finger surgery or a brutal hip or knee surgery. These are the post-op x-rays. You can see that I admit the patella looks tiny bit high, but not too bad. We've got the rotation right, we've got the height right, and the patient was happy walking in a few days. Case number 3, again, we're looking at a distal femur fracture in a 59-year-old female, but look at the size of that female. She is 150 kilogram with a BMI of 60. Now, this was a challenge because obviously of her size as well. You can see that the distal femoral spike is very close to the joint line. So one could argue, yeah, you put double plates and you could do it. So again, you could decide what suits you, what you're comfortable with. But what we thought is to do a nail plate construct. The important key in this is to reduce the fracture as best as you can before trying to stabilize it. So you can see the Hagrove's retractors reducing the fracture, and then we've got the fracture reduced with a locking plate, and then used an intramedullary, conventional retrograde intramedullary nail with some cables around to further stabilize the fracture, well, the construct rather than the fracture. And we've put the proximal locking screw through the nail to have even a better implant construct. You can see this post-op x-rays. You can see the proximal screw that is actually going through the nail, and some unicortical screws, some cable plating, and locking screws distally. The advantage of this is that look at the size of the patient. She's never ever going to tolerate non-weight bearing, so we wanted to get her going. We fixed it, and we let her partial to total weight bear, essentially weight bear as pain allows, and she's done well. Probably my last case. This is the different end of the knee. Is this the distal proximal tibia fracture? Again, 50, a younger patient, but very poor, unpredictable patient. Compliance was an issue because we knew she was a chronic smoker, 20 cigarettes a day. 60 cigarettes a day. She also had some short-term memory loss. So I wasn't sure whether she will be compliant with non-weight bearing if we just put some plates across it. So you can appreciate the fracture. There's a proximal fibular fracture. There's a lateral tibial plateau fracture, which extends into the shaft distally. So she's got a combination of a tibial plateau as well as shaft fracture. As always, have a plan A, B, C. So what we did is we firstly approached the lateral side of the tibia with the lateral approach, temporarily put a lateral proximal tibial plate with some screws across, then put a buttress plate on the medial side through a small incision. Now, what that allowed me is to absolutely reduce the fracture posterior-medially, and temporarily held it with a couple of screws through the buttress plate and wire. And once that was in, we were happy the fracture wasn't going to move. I just went through a suprapatellar approach, put a suprapatellar nail in, and then fixed the lateral plate with some locking and non-locking screws, and then finished off the nail and the medial blade. These are the post-op x-rays. Now, I think these are about 6 months down the line, or probably nearly a year. Patient's happy, mobilizing from day one, and has done well. A quick word about periprosthetic fractures. These can obviously We all know if the implants are stable, we try to fix them. Just like that, it doesn't matter what type of what company you use, any good locking plate screw system will help reduce the fracture with cables or wires temporarily, and then get a distal and then get a locking plate with good amount of screws. Obviously, you don't want to fill the whole bone with metal, otherwise you will not have any potential for healing, but good enough construct to make sure that you've got a balance between absolute versus relative stability. Now, some fractures can't be fixed, periprosthetic fractures with loose components. These can be, these need some special expertise for revisions. This fracture on the left side, you can see it looks like a straightforward oblique, but it wasn't. The fracture was extending right into the femoral neck. The split was going up. So obviously this was appreciated when we did the revision. And I want to make sure that the GT fragment was stable. Otherwise, we risk dislocation and non-union. So we've fixed it with a GTR claw plate. And the patient's was for mobilizing straight away with no restrictions. One last case is again a distal proximal femoral fracture with a loose stem. Preoperative planning. That's what I would stress. This is the most important case because you get the length right, the components right, and you reproduce what you've templated. Obviously, the proximal wire has cheese wired through the bone, but not a problem because this is a diaphyseal fix, a press fit diaphyseal fix fixation implant, and again, no issues post-op. So in summary, we always consider the patient in total as a whole rather than only the fracture. It's extremely important that you discuss these in a multidisciplinary setting, bounce off ideas of each other, and have more than one plan during the surgery, and also make sure if there's a complete fracture that you've got right post-operative setting, and maybe an HDU and ITU setting as well. You pre-template it. Always consider all these factors. What's the pattern? What are the comorbidities? Should I fix it or replace it? How much time I'm going to take it in order to make the fracture look better versus is there something else I can do which will achieve the same or even better in a shorter time? And always respect the soft tissues and preserve the bone biology. We need to know our limitations. I know we are all skilled surgeons and we think I think I can do a spinal fracture fixation. I can do a peel on ankle. I can do a shoulder fracture dislocation. It's not a question that I can do it, whether I can do it well, and do I do it enough? Do I have the skills? If you don't have it, do not feel shy to give it to someone else who does more of these and probably will do a better job than the others. Thank you very much.
Thank you so much, Mr. Azal, for this very interesting presentation. Thank you so much. It was a very comprehensive presentation, sir. Thank you so much, sir.
Thank you.
Thank you, sir. Our next speaker will be Professor Arshad Khalil. Professor Arshad, you are with us?
Sir?
Sir, how are you, sir?
I'm very well, Prof.
It's
how are
very
you?
nice to meet you again, sir.
Thank you very much.
Thank you so much for being with us, sir. Thank you so much. Professor Arshad will speak about ankle instability, use of internal brace outcome. Very interesting topic, sir.
If you allow me to share the screen, I cannot share screen yet.
Dr. Azal, would you please stop sharing screen, sir?
You're having a marathon session, sir. This is awesome.
for more than 12 hours, sir.
I can just imagine. Okay, sir. So
can you Professor Imam?
He's mashallah, he's doing very well. Thank you.
Thank you, sir. Thank you, sir.
Can you see my screen?
Prof, this is Azal here. I've logged off. Are you back in, Mr. Khalil?
I am, sir. I am. And can you now see my screen?
Nice seeing you, Prof. Again, take care.
Yes, sir. We can see it.
All right. So
thank you, Dr. Azal. Thank you so much.
Pleasure. Most welcome. Thank you. All the best.
Thank you, sir. Thank you, sir.
After those fantastic talks, I'm just going to try and keep to keep it simple. Now, ankle joints are are probably one of the most common injuries, but they are not as popular as the knee injuries or as high profile as knee injuries. Now, the ankle joint is injured through twisting. So the joint has 6 degrees of freedom. It has.
Sir, would you please make full screen, sir?
Okay. Is
Yes,
that
sir.
better? I'm
Yes,
so
sir.
sorry.
Thank you, sir.
So,
Thank you, sir.
what I was saying was that the ankle joint is injured through a twisting force, i.e., torque force is applied. The ankle is a combination joint with 6 degrees of freedom. The primary stabilizers when the joint are loaded are the bones and the ligaments. These work well in the static forces. However, injuries occur in the dynamic phase, and here the peroneus longus and the peroneus brevis become very important in maintaining stability. The history tells us whether the injury is acute or chronic, and we get the classical history of instability on uneven grounds. Examination confirms in the acute stage, but in the subacute stage, we do the anterior draw to demonstrate instability. But the most important point of the examination is to look for secondary factors that could cause instability, such as hyperlaxity or typically the cavo-varus foot. The X-rays are sometimes this helpful, but the more important role for the X-rays is to find other injuries, such as an osteochondral injury, because this will have a significant impact on treatment. The MRI scan is the mainstay, where we can grade the injury, we can look for other associated injury patterns. Initial management is fairly traditional of rest and mobilization, and there is very good results of active functional rehabilitation, and the results of that are proven. So that with these active exercises, we can get about 8 out of 10 ankles to become stable. Hence, being such a common injury, majority will do well with therapy. Unfortunately, about 2 out of 10 will continue to be unstable. And historically, anatomical and non-anatomical surgical procedures have been described. And if you look at the outcome of these, it's interesting. So in this series, where they had athletes, at 10 years, only 50%, just over half of the athletes had actually gone back to their injury level using an anatomical repair. In my hands, the scope I use for intra-articular lesions. I don't use them routinely for ankle instability. And my protocol is exactly the same, where the diagnosis and examination is done. The patients must have physiotherapy, and surgery is only offered if the ankle has been unstable for at least 2 months after therapy. MRI is the mainstay. I only do EUA very rarely now. This is my series. We were able to review patients before COVID. So the surgical technique is a Brostrom anatomical repair of the ATFL and CFL using fiber wire, but I augment with the internal brace, and then I augment even more with the inferior retinaculum. I allow immediate weight bearing, and patients have physiotherapy, and they can return to sports around about the 3rd month. My series, we now have over 100, but these were, when we reviewed them, they were just under 100. Majority were boys. Thankfully, we're lucky enough not to have any infection. We used a validated scoring system, and as we would expect, 8 out of 10 patients had stable ankles. We identified that the poor outcomes were those with other injuries to the ankle, so they were not straightforward ankle instability. So this is what I do. I always put a bump under the ankle so that the ankle is free. The main reason for this being that this stops the ankle subluxing anteriorly. I use an anterolateral approach. I look into the joint to make sure that there is no meniscoid lesion, which are basically either CFL tears or bits of cartilage that have come off, or look for OCD. I first place the internal brace into the talus and the fibula, and then do the rostrum repair. So the brace is placed, and then it is overlapped over the rostrum. So it's an extra articular augmentation. And one arm of the brace can also be used to do the CFL, but remember that we have to go below the peroneal tendons for that. And then I do the Gould's repair. If like in this patient was a cavo-varus foot, I always do the ankle stabilization procedure after all other procedures, such as the heel shift or the first ray surgery. The reason why I use the internal brace is that it is actually a pretty strong structure. It is stronger than the native ligament, and I have no control over the quality of tissue. So when you're treating hyperlax patients or patients with chronic instability, or those simply with no ligament, no ATFL at all because of the chronic instability, the internal brace is reassuring. Some of my patients' main exercise is getting to the fridge and back. So I really have no control over the patient-related factors. So yes, the internal brace works. It gives predictable outcome, and it is safe to use. I'll also touch upon something on the syndesmotic injuries. For us, the main problem of the syndesmotic injury is identifying them. Now, sometimes they're obvious, but often we discover them after the procedure in the check X-ray when we should have identified them. So Master Nawaz has gone off. When he was still troubling me, we came up with this idea, which was to stick some dye into the joint. And if there is a syndesmotic injury, what we notice is the dye traveling up straight away. And if there isn't, the dye remains in the ankle mortise. More importantly, once we have reconstructed the syndesmosis by any method, we can still stick the dye in to see whether we've reduced the syndesmosis, and we find this very helpful. People have their own number of screws and whether they should be bicortical, but I think the tightrope has now become universal, and even a dinosaur like me has learned how to use it. Synostosis is probably the hallmark that we were unable to stabilize the syndesmosis. In my life, in my 30 years, I've repaired the deltoid ligament twice. Main reason for being that we need to understand that it hasn't got a single point of insertion, especially on the tibia. So the modern braces allow a multifold reconstruction of at least the deep part. And that's all I have to say about ankle instability, Prof.
Thank you so much, my dear Professor Arshad Khalil, for this very interesting talk. And thank you so much for supporting us all over 3 years ago, sir.
It's a pleasure. Thank you very much.
Sir. If we have any questions to Professor Arshad. Okay, I think we have to go to the next speaker.
Thank you very much. Thank
you, sir, because we are out of time.
I can imagine.
Thank you, sir. Thank you so much, sir. Our next speaker will be Mr. Nagui Fayo from Frimley Park Hospital. Mr. Fayo will speak about calcaneal fractures. And before I introduce Mr. Fayo, I want to thank from the bottom of my heart my dear brother and my dear friend, Dr. Rami Sharif from Frimley Park Hospital, for sponsoring and arranging and moderating this UK session. Thank you so much, Dr. Rami, for your great effort for more than 4 years with me. Thank you so much. Now we will go directly to the talk of Mr. Fayo. Mr. Fayo will speak about calcaneal fractures. Sir? Mr. Fayo? Mr. Fayo, you are with us? Okay, I think we have to postpone the talk of Mr. Fayo. Now we will go to the next speaker. The next speaker will be Mr. Mohammed Hussein. Mr. Mohammed Hussein from Frimley Park Hospital. Mr. Hussein will speak about hemi-hemi transfer. Mr. Hussein, you are with us?
Hello, can you hear me?
Yes, sir.
Hi. Yeah. Okay, can you see my screen now?
Yes, I can see it, sir.
Okay. Okay. I'd like to thank Rami, my colleague, and use Dr. Mohammed Al-Ashar for letting me present my case I did with my consultant, Mr. Alex Vaughan. First of all, I'm Mohammed Hussein, one of the trauma and orthopedics registrars in Frimley Park Hospital. I graduated from Alexandria University in Egypt in 2010, and I moved here to the NHS in 2018. I just want to present a very interesting case that we don't see very often in our practice. It's basically a hemi-hemi transfer on arthroplasty in a chronic PRPJ fracture dislocation. Just reminding everyone about the literature, intra-articular fracture dislocations of PRPJs have always been very difficult to treat, and a lot of these cases are either treated conservatively, even though they might need surgical intervention. And oftentimes, when there is an actual person who knows how to deal with these injuries, it's often very late, and patients are reluctant to do anything about it, because when they come to know about the major reconstructive surgeries that they need, a lot of people are scared, and obviously some surgeons are would not want to do these kind of surgeries. Majority of these patients are young, fit and active individuals, usually males, 20 to 50 years, with injury being during sports. Most of the time axial directed forces with a hyperextension, hyperflexion. Most common direction is the dorsal dislocation, but obviously it can be in any direction, volar, lateral, or rotatory. It can be either a simple dislocation or a fracture dislocation, which is the scope of my talk today. Mechanism of injury, as I said, is usually a direct blow, and the pathophysiology is either an avulsion injury or an impaction shear. If it's too comminuted, we give it the name pilon fracture, similar to the pilon fractures of the tibia. As I said, either an avulsion injury or a shear transfer. It's either if it's an avulsion, it's usually dorsal or volar, according to the direction of the force, with a hyperextension. If it's dorsal, the finger goes into hyperextension, followed by a failure of the volar plate, and then avulsion of the volar lip of the phalanx, and fracture. If it's a volar directed force, then it causes hyperflexion, and a failure of the central slip. This is if it's an avulsion injury. If it's a direct shear force, then it's an axial loading with a PRPJ in a flexion or extension, and obviously that can cause a fracture dislocation in either direction.
Dr. Mohammed, I think the slide is not moving. It's the first slide, DC.
Yeah, I'm going to move in a second. I'm still on this slide.
Sir. Thank you. I'm sorry. Thank you.
No problem. History clinical examination, obviously essential. Clinical examination is very important. Obviously, systemic examination to rule out any other injuries, but concentrated on hands to identify any wounds, any other injuries, any other fractures. And in dislocations, deformity is usually easily identified clinically, but as always, you definitely need x-rays to clarify how much of the bone is involved, as well as if there's any other injuries. And the first time these fractures were actually classified with a proper classification was by Hastings in 1988. And he classified it according to the percentage of the joint surface that is involved. Less than 30%, 30 to 50, and more than 50% of the joint surface, less than 30% usually stable and can be treated with closed reduction and closed splinting. 30 to 50% stability is tenuous. It might be stable, might not be stable. And that falls, obviously, differs from one patient to another. And that is a kind of a gray area. Some surgeons think this is stable, I'll treat it conservatively. Other surgeons think, no, I'll probably fix it. More than 50% joint surface involvement is usually an unstable injury and would need a surgical intervention. Management, as I said, conservative or surgical. Conservative can be either a closed reduction, splinting, extension block splint, or just an extension splint, or a body strap. Simple body strap is more than enough in simple dislocations or very small avulsions. However, if we come to the surgical intervention, can be closed reduction and pinning, or open reduction and fixation. There can be many different procedures. If it's too comminuted, like a pillant fracture, then you do a dynamic distraction. Otherwise, you can do a volar plate arthroplasty if someone is an experienced surgeon, or arthrodesis. And lastly, which came in recently, is my scope of my talk, is the hemihamate arthroplasty. I'd like to thank Mr. Alex Vaughan, my consultant, whom I did this case with. This is a 26 years old female athlete, presented to us with a chronic fracture dislocation in her right middle finger, PIPJ. The injury happened in June 2022, and unfortunately, because she had COVID, a long COVID, we could not fix her in an appropriate timing. She presented to us in November after resolution of COVID with the injury. Her finger was in fixed extension. There's not 0 degrees of range of motion in her PIPJ. The IPJ was normal, 30 degrees of flexion, and she had a full range of motion in her MCP. These are the images when we first saw her in November. As you can see in the first image on the left, the lateral view shows an involvement about nearly 50% of the articular surface, and the AP views as well showed a bit of rotatory instability and a displacement of the fracture. So we decided to take her to theaters. She definitely needed surgical intervention. She could not do anything normal daily activities. And it's very important, before I proceed to talk about the surgery, it's very important selection of the patients. You have to pick up the right patient. You can't just say with any patient that presents to you with a similar injury, okay, I'll do that kind of surgery for him. This is a very complex surgery with a lot of you need a patient who's well educated and has expectations, and you know that this patient will not, I don't want to say like mess up your surgery, because the last thing you want to do is to do a very complex surgery in a patient who will not appreciate that and will not follow your instructions, and after a few weeks the surgery will fail because the patient did not simply follow your instructions. So you need to select the right kind of patient. Obviously you can't do it in an old frail patient, and you can't do it in a manual labor. You need to do it in probably an athlete, a young patient, well educated, knows what the surgery is like, and is aware of the complications and the duration of treatment. And obviously that will lead you to a big discussion with the patient and a consent before proceeding. So to cut it short, we've taken the patient to theaters, general anesthetic, tourniquet, supine position, made an approach. As you can see, it's a curved incision over the PIPJ with an ulnar base, sorry, a radial based flap, but the incision is towards the ulnar. We lifted up the flap, exposed the flexor tendons, as you can see, FDS and FDP tendons, we released the A2 pulley and A2 and A4 pulley completely to facilitate the release of the tendons. And then, as you can see here, mobilize the tendons, move them to the side, protected the neurovascular structures, the two bundles on the sides. And then this approach is commonly known as the shotgun approach. I'm just going to post a picture here. It's called commonly known as the shotgun approach. As you can see in the image, it's similar to a shotgun where you do a volar incision, open up the capsule and release everything, and then you flip the finger completely to expose the articular surface. This image is where we've taken just an X-ray with us to make sure that we are definitely in the right joint, although it's obviously easy to identify. But this is after some release of the fibrosis tissue that was around the joint itself. And then we did the shotgun approach, as I mentioned. This is the view from top, where you can see here the forceps actually pointing to the articular surface, the fractured articular surface. It's depressed, comminuted. I think the image is not very clear, but it's depressed, comminuted, and obviously rough. We cleaned it, taken out all the debris from it, cleaned out the non-united and non-healed bony fragments, and got to a clean, healthy bony surface. We got to this stage, and then we proceeded to make an dorsal incision over the hamate. This is an X-ray image to identify the hamate bone. As you can see, there's a dorsal incision, self-retaining tractor pointing out to the hamate here. And then we made using a saw, a small saw, as you use for similar to the hallux valgus procedures or any other hand procedure. We had measured the defect. It was about 1 centimeter by 0.8 centimeter in size. And we proceeded to put K-wires as a guide to where are we going to cut in the or saw in the hamate. Made the cut. We usually try to make it slightly bigger in case you need to trim it. But when you trim it, you don't want a smaller size than the actual defect, which will cause a problem. So you take a slightly bigger size of the hamate, and then you cut it with a saw. As you can see, this is after taking the fragment off. And as you can see, the rest of the hamate is left intact and clear without any other fractures. And then, so we proceeded to take that fragment, clean it, size it exactly to the shape of the defect. And then we placed it over the defect, trying to make the articular surface of the hamate itself articulate with the condyles of the proximal phalanx, and then we managed to initially fixation with a K-wire and testing it in flexion and extension, making sure that the fragment is well fixed and stable, and then fixed it with 2 screws about 1.3 centimeter in size, Sinti screws. Each one of them was about, as far as I remember, I think 10 millimeter length, which is actually a 1 centimeter length. Fix it with it, and again try to bury it. These screws, they are very good because you can actually bury them in the articular surface if you want to, or whatever direction you're going to fix the screws. In this case, we fixed it, as you can see in the X-rays here, from a volar aspect, because it seems more reasonable and was easier to do rather than through the articular surface. And then we tested it in flexion and extension to make sure that the screws are stable. And the bony fragment is stable. The finger is not dislocating. Surgery took us, I think, about 2 hours, if I remember correctly, and put the patient in a back slab for about 1 week. And I have to say here that the hand therapy is very important. So you have to have a good correlation with your hand therapy team. And again, the patient has to understand that this surgery is a very complex surgery, so they need to follow instructions of the hand therapy team. We brought her back after 1 week, made sure the wound is clean, and then after the 2nd week, took out the stitches, and then started the hand therapy straight away. Gentle movements in flexion and extension, but most likely blocking the extension not to lose the fixation until the fragments become sticky and they starts to unite. This is 6 weeks later. As you can see, I'm sorry, there's no lateral view here, but you can see that the Brownie fragment is well fixed in a good position, and that is in 12 weeks time. Bony fragment completely united. Patient had a full range of motion, flexion and extension in her PIPJ. No pain at all, was back to her normal daily activities. We were a bit conservative of her starting the sports, but we allowed her to start after 3 months, which is about that time. And by that time, she was actually discharged from physiotherapy. And that's really what I wanted to talk. But thank you very much, Rami, my colleague, and thank you, Dr. Al-Ashab, for allowing me this chance to present my case. Thank you.
Thank you so much, Dr. Muhammad Hussein, for this very interesting case presentation. We can allow just 2 questions to you, sir, because we are out of time. We have 2 questions to you, sir. First question, did you repair the volar plate to the fragment after fixation, or do you leave it?
No, of course. So I did repair it with Mr. Alex Phone. Yes, we did repair it. It's very important to actually repair it and then make sure that the flexor ligaments are sliding smoothly over the volar plate. Make sure that there is no any catching in the ligaments to allow for the early mobilization.
Yes, sir. Another question: how stiffness and tendon adhesions could be avoided while still graft stability to be preserved?
So again, this is what I mentioned by the patient selection. So you instruct the patient gentle movements, mostly in flexion, and start by passive gentle movements. You put a dorsal slab to avoid overextension, but gentle movements passively first 3 weeks, and then gently they start active flexion.
Yes, thank you so much, Mr. Hussein, for this very interesting case presentation, and hoping to see you again, sir. Thank you so much. Thank you so much. Would you please stop sharing screen, please?
Yeah.
Yes, thank you. Our next speaker will be Mr. Nagui Fayo from Frimley Park Hospital. Mr. Fayo will speak about calcaneal fractures. Mr. Fayo, thank you so much for joining us.
Thank you, Prof. Al-Ashab and Rami, for inviting me to this educational event and
thank you, sir,
and giving me an opportunity to talk. Let me share my screen. Can you see it?
Yes, sir.
My name is Nguyen Pio. I'm foot and ankle consultant from Frimley Park Hospital in the UK, and this is our hospital. Just for those who don't know us, we are in southeast part of United Kingdom and not far from London. And I have nothing to disclose regarding this topic. I'm going to talk about the calcaneal fracture, which is common as tarsal bone fracture in adults, and it's most of the time it's a high energy injury falling from height. Most common male between 30 to 60. It's very devastating injury and with severe consequences and delay in return to recovery, affecting patients' ability to walk, wear shoes, and return to its function. The mechanism of injury is mainly that fall from height, leading talus to wedge into the calcaneus, causing either intra-articular or extra-articular fracture. As you can see in here, the primary fracture line will be in the middle with the multiple split, dependent on the energy level pertained. So just to give idea of how the fracture can be visible on the images. And I will just go through quickly for the images to share the fracture pattern. Traditionally, we look at X-rays to assess the calcaneal fracture and the degree of collapse. We usually use 2 key radiological marker, as in measuring the angle. As you can see here, it's a Bolo angle and the critical angle of Gissane to work out the loss of calcaneal height and an articulating surface. I just want to share that this is the X-ray of a patient with the severe calcaneal fracture, where you can see the border lines completely depressed and suggesting that this patient may require surgery. And people has created multiple classifications, and the most common ones that we use are SS Lopresti classification and Sanders classification. There are others, but the two that I just mentioned are the commonest one to use. And I will go through this quickly for the sake of time. And in SS Lopresti fracture, it's tongue type and the joint depression type, depending on the degree of energy involved. Whereas in Sander, the CT scan is used to assess fragments involved in the fracture pattern and ranging from type 1 to type 4. And for me, for practical purpose, when I look at the X-ray, I work out whether it is intra or extra-articular, or whether it is displaced or undisplaced before I make treatment plan. So a lot of controversy is around calcaneal fractures treatment, especially in the UK. It is because of this paper that was published in 2014 by Griffin Group in the BMJ, saying that calcaneal fracture does not get any real benefit from surgery. This paper has caused shockwave and unhappiness in our foot and ankle society, and because the hospital management people will come and say that what is the point of fixing these calcaneal fracture when there is a paper saying there is no benefit. But this paper has multiple weaknesses. They have over 2,000 people screened, and out of 502 eligible patients, they have only randomized 150, and over 350 patients were not randomized because these patients require surgery. And they reported that surgery has no real benefit in their short-term follow-up of their 2-year study with 17% complication. So when one look back, this is a great study, randomized control study from Buckley Group from Canada in 2002. In the literature, this is the paper with highest number of patients randomized, of 200 patients in each arm, operative versus non-operative for calcaneal fracture treatment. Upon looking at, on a general looking at it, they found out that there is no significant difference. But when cases are stratified, Buckley reported that women, younger men, and high comminution fracture are better served with surgery, whereas men over 50, workers' compensation group, and heavy manual labor may not have significant outcome. And also 5 times higher likelihood of subtalar joint fusion as a consequence. So subsequently, this paper is in 2013 from Swedish group, and they looked at it, and of their patient, it's about 40 patients in each arm, operative versus non-operative surgery. They found that there is no real difference at initial 12 months, but longer outcome, they reported that some benefit in the patient who had surgical fixation, and also reduced the post-traumatic arthritis in this group. And this is subsequent paper from Griffin Group from earlier report on the BMJ. This is their 5-year outcome report, and they still report that there is no difference in outcome. So finally, and in recent systematic review, current best evidence suggests there is advantage for operative treatment. So, but one has to approach with caution when dealing with calcaneal fracture. You have to consider patient smoking status, diabetes, and whether it involves workers' compensation claim and mental health. What if not treated surgically? Obviously, a patient will suffer malunion, causing difficulty with walking. And also, talus will sit up, causing stress, and lateral wall impingement, irritating the peroneal tendon, and will have ill-fitting shoes. And this will be difficult in some patients and who need to wear walk boot with a steel toe cap to get the job. So what are the indications for surgery? Obviously, if the injury is associated with ankle fracture or subtalar dislocation, ankle dislocation or subtalar dislocation, you have to do something about it. What about lateral wall blowness so significant that it's causing subfibular impingement? You have to do surgery to get it back to where it should be. And obviously, needless to say, if it is open fracture, you have to deal with it. So objective of the surgical treatment is that to reduce the lateral wall and to restore the calcaneal height and length, and also hindfoot varus and valgus alignment. And if possible, you want to recreate the posterior facet and to prevent occurrence of subtalar joint arthritis, and you want to aim for early mobilization. What options do we have? Traditionally, if these calcaneal fracture were treated with open approach, doing extended lateral, but it was associated with high risk of wound breakdown and infection. So people has slowly moved away from open surgery to less invasive surgery. And another option is that one can consider doing primary fusion of subtalar joint in a highly comminuted Sanders type 4 fractures. In approach, this is the traditional approach. I personally have used it many times, and I like that as well. If you handle it with care, you can do great job with this. And it will involve full thickness flap raising, and you reduce the fracture under direct vision, and also put the plate and bone graft. But the problem is that one has to be very meticulous about wound handling, and they have a risk of soft tissue complication and infection. This is a disaster. If that happens, it is difficult to manage and psychologically impacting to patient and also to you, and to lose confidence in handling this. And another approach, which I have using more and more these days, is a sinus tarsi approach. It's a small opening. You reduced it indirectly with the help of a fluoroscope and your wires and McDonald elevator, and then you put screws in a key position to maintain your reduction. And myself, I'm a big fan of putting bone graft, allograft bone graft, cancellous, in these patients because that I feel that you have to impact the bone graft too, and to prevent the collapse. So this is my route. It is my routine practice to use bone graft, and this is you can see that only 4 screws were used to fix the calcaneus with a bone graft in there. So, and there are more techniques. People use percutaneous approach on this. It is evolving. One just used K-wires and screws and shunt spin. However, I personally feel I never tried this approach. I'm just sharing this as a complete for completeness, because I would like to see where the fibular peroneal tendons are before I put the screws, so that there is no tethering. And this is again evolving. So I just would like to share a few cases with the audience about my experience as well. So this is the first case where you can see the obvious subtalar joint dislocation with the medial fracture, and here you can see the fibular edge has been pushed from the calcaneus. So for this, I went in through medial approach to fix the sinus tarsi, and then also put a small plate on the back of the fibula to get the realignment, and patient was quite happy, and rehabilitation went quite well. So second case, this is a bilateral case where on the right side you can see pilon fracture, talus fracture, and the calcaneus fracture. On the left is severe calcaneus fracture. So this is the outcome following the surgery. So I didn't do it on one sitting, but one can be done if you have time to do that on one sitting, but it's tough to do. So the third case that I would like to share is open fracture. So here I try to avoid using heavy metal in there. So I mainly use wire to hold the reduction. And here I used ceramic white filler to take the space, and we maintain the wire. We leave the wire for at least 6 weeks, and then treat the wound with VAC dressing. So this is a final case which I did yesterday. Again, this is a bilateral calcaneal fracture, severely comminuted. This is 21-year-old female patient who jumped from height to commit suicide. In addition to her bilateral calcaneal fracture, she also have L4 bus fracture, which require operative stabilization. So this is now 2 weeks that I went in yesterday. So this is her 3D images. As you can see, blowout on both lateral and as well as medial wall. Sorry, it's so this is to show how blisters, especially the left side one here. This one is significant blister because she has the medial wall blowout and led to severe soft tissue edema in there. So I started with the right side first, and to see how it goes. So this is again sinus tarsi approach, me elevating the fracture fragments, and I hold it with K-wire, 2 K-wire, and then I went on and using the plate. And of course, as I said earlier, I used the bone graft in there. So this is, so I proceeded to the other side, again, sinus tarsi approach, elevation, bone graft, plating. So now I will go on to tongue-tied fracture, which is a different beast to intracalcaneal fracture, intra-articular fracture that I mentioned earlier. For these tongue-tied fracture, these need to be treated urgently unless it is undisplaced, because they are associated with high risk of skin compromise, and usually they cannot wait for a foot and ankle surgeons to come and do the surgery. I think it's general orthopedic surgeons have to deal with it. And here you can see the skin necrosis starting out at the back, and this is how I would normally fix this. I use large 6.5 cannulator screw with a washer to hold it, and then I keep the patient in slight plantar flex position to detension the Achilles. So if this is left untreated, this is how it's going to happen. The skin necrosis will continue, and the breakdown, before you know it, it will become open fracture. So this is something that there's no controversy about fixing or not fixing. So in terms of post-operative, I keep the patient in the plaster cast for 6 weeks and non-weight bearing for 6 weeks. And then I will gradually mobilize them out of the cast with the crutches and then physio. So in conclusion, calcaneal fractures, they are challenging, but one has to treat patient individually depending on their characters, the presentation, the pattern, fracture pattern, and you have to choose your approach carefully. And and needless to say, meticulous soft tissue handling is required. But most importantly, you have to enjoy it. Otherwise it will be painful for a surgeon to go through that. I enjoy doing calcaneal fracture. It's a challenge, but I love to take it on. Thank you very much.
Thank you so much, Mr. Fayo, for sharing your experience in this very important topic, which is calcaneal fracture with us. Thank you so much, sir.
Thank you, Prof. Al-Sharab.
We have just one question from Dr. Gamal Qasim. subtalar fusion versus operative intervention before the age of maturity?
Well, subtalar fusion for intracalcaneal fracture, I have only done 2. I am more towards fixing it. So, and it is difficult to get the position right, and so not for me.
Thank you so much, Mr. Faig. Hoping to see you again with us, sir. Thank you so much.
Thank you, Prof. El-Shahab.
Thank you so much, sir. Our next speaker will be Mr. Ahmed Al-Maghrabi from Friendly Park Hospital. Mr. Al-Maghrabi will speak about posterior malleolar fractures. Mr. Ahmed?
Hello, hi.
How are you, sir?
I'm not sure if you guys can see me.
We can hear you, but we cannot see you. Yeah, we can.
Yes.
We can see you now. How are you?
I'm good, thank you. How are you, Professor Ash? I'm just about to share my screen.
Yes, please, sir.
First of all, I'd like to thank you all, Professor Ashab and Rami, and all the people involved in actually arranging this huge event. And as I heard, it's probably the largest in context of the numbers and the hours and everything. So thank you very much for the effort. And I've been lucky enough to present last year, and again, I'm lucky enough to be among you today. So thanks for having me. I go by 2 surnames, and sometimes this is confusing. So some of you guys might know me as Ahmed Abdelaziz, and some of you might know me as Ahmed Maghrabi. So don't get confused. I'm the same person, and I'm not running away from any crimes, I promise you. I'm a foot and ankle consultant in University Hospital Southampton. I worked with Rami when he was in Southampton, but I don't work infirmly. And I'm a lecturer of trauma and orthopedics in Cairo University, which I'm very proud of, and the place where I learned. Well, I won't say.
Sir, you are working with Professor Wagih Musa.
Yes, I am. Yes.
Yeah.
My
Greetings for him, sir. Greeting for him.
I will pass that on, definitely. I'll try. I know it's a very dense day, and probably everyone's tired and exhausted and will be by the end of the day. So I try to be sort of, instead of just going through ankle fractures in general, I try to be very specific to what I'm talking about today. And I think it's a matter which is slightly controversial. Some people might not have the full updates on it, so I hope the presentation will be beneficial to you guys. So posterior malleolus. Conflict of interest, I have nothing to declare related to this presentation. So I think by the end of the presentation, I'd like to answer 3 questions. Why do you fix posterior malleolus? When do you fix the posterior malleolus? And how do you fix the posterior malleolus? So I'll start with why. So we fix the posterior malleolus for 2 main reasons: stability and congruency. Stability, not only the syndesmotic instability, so we know the 2 main ligaments of the syndesmosis are the AITFL and the PITFL. And there have been different arguments as to which ligament is more important. Is the AITFL or the PITFL or the interosseous ligament? And some people think that the PITFL is the main stabilizer for the syndesmosis, and it's the main stabilizer against rotational instability. So one of the purposes we fix it is for syndesmotic instability, to prevent or to treat syndesmotic instability. And the other purpose is actually to prevent, especially with the large fragments, to prevent the TPU talar instability as well. So the large fragment can make the actual ankle joint itself unstable and can sublux anteriorly. The second, it's like any other articular fragment. Again, especially if it's a big fragment, it can affect your joint congruency. If you have an articular step, then it can lead to arthritis, stiffness, and pain. So in a sense, it's an intra-articular fracture. So when do you fix the posterior malleolus? Please completely forget the rule of thirds. No one follows the rule of third anymore. It's been hugely criticized, especially in the last 5 years or so. So the rule of thirds doesn't apply anymore. The rule now is, generally speaking, if it's big enough to be fixed, then you should fix it. Again, the classification has been updated. There are 2 brilliant foot and ankle surgeons in Liverpool, Mason and Malloy. and they've been working, well, not exclusively on posterior malleolus, but I think they're publishing almost exclusively on the posterior malleolus in the last, I don't know, maybe 7 or more than that. So they kind of updated the Haraguchi classification, which was sort of more familiar and more popular. And it's not very different, but I'll come why this classification is important in a minute. So type 1 is a sliver fracture, or it's a very small fragment, which most people will shy away from fixing, and I think it's really hard to fix. Type 2 goes into 2A and 2B, and the difference is 2A is only a posterolateral fragment, whereas 2B is a posterolateral and a posteromedial fragment. And type 3 is the almost pilon fracture, where you get a really big chunk at the back of the tibia. And in my opinion, actually, this is the hardest. So when I started doing these fractures, I thought this is a big fragment. It's not comminuted. It should be relatively easy to fix. Quite the opposite, actually. This fragment is the most, this type is the most actually difficult to reduce, especially if you're doing it 2 weeks down the line or something. So the beautiful thing about the Mason-Miller classification is actually it has implications on how, so it's sort of for the simple-minded people like myself. So if it's type 1, you don't worry about fixing the posterior malleolus, you just fix the syndesmosis to achieve the syndesmotic stabilization, and hopefully this small fragment will come up with the rest of the tibia and the patient shouldn't have any problems. The reasons they split the posterolateral and the posteromedial fragment into 2A and 2B is 2A, you can go posterolateral approach, which I think the majority of us, even general orthopedic surgeons, are familiar with now, and people have been doing it increasing numbers over the last few years. The 2B is, I think, slightly tricky, so you still can fix it through a posterolateral, but you'll have to combine that with a medial posteromedial approach, or you can go posteromedial altogether, so you can access both the posterolateral and the posteromedial fragment from the posteromedial. For type 3, and again, this is controversial, so they recommend going posteromedial, and I would agree, having tried posteromedial and posterolateral for that type of fracture, but some people will still do it through posterolateral. Important thing to note, just to come back to this slide, sometimes the posterior malleolus, the posteromedial fragment, sometimes it's actually, because this is the constant fragment, like the posteromedial fragment of the calcaneus, we call it the constant fragment as well. So sometimes you cannot reduce, I'm not sure if you can see my cursor, but sometimes you cannot reduce this posterolateral fragment unless you reflect this posteromedial fragment out of the way, then you can push that posterolateral fragment back in, and then you go and fix the posteromedial fragments. So I thought I would not waste your time about talking about posterolateral approaches. It's everywhere. If you haven't done it, probably you have seen it. So I think most of us familiar with the 2 windows, the one which is between the FHL and the peroneal tendons, and the one lateral to the peroneal tendons. I think the relatively new approach, which I am keen to talk to you about, guys, is the posteromedial approach, or approaches rather. It's 3 different intervals. So there's a posteromedial approach, there's a modified posteromedial approach, and there's a medial posteromedial approach. So start with positioning. So positioning is key in my opinion. I've almost moved completely away from prone position to posterolateral and posteromedial approach, and I'm doing everyone almost exclusively as what we call the recovery position, or the lazy lateral. The anesthetists love this position because they don't have to worry about all the technicalities and the difficulties of putting a patient in a prone position for an extended period of time. And yet you get an almost prone position on the lower parts of the body. So if you lie in the position and then after patient's asleep, you just twist the hip, internally rotate the hip, so you almost get a completely prone position on the ankle. Obviously, it's not for every patient. It has to be in patients who are sort of average or slightly slim. And again, remember that they have to have flexible hips. So if they have stiff hips, or if they have total hip replacement, you have to be very careful. So lots of these patients we treat in the UK have actually total hip replacements. The other position which sometimes you can use is actually keep them supine and just do your medial posteromedial approach through the figure of 4 position. You just have to have 2 assistants most of the time, someone who'll be bored and you just be pressing and keeping the knee in that position, and someone would be actually assisting with the surgery. So the 3 intervals described, as if you go, this is the tib post tendon, and your incision normally goes almost over the course of the tib post tendon. You identify the tib post tendon, and depending on your fracture and what you want to achieve, you can either go anterior to the tib post, and this is slightly uncommon because in the past people used to do it because they thought that this is the safest approach, because if you think about your bundle, the bundle is actually protected by your tib post, it's protected by your FTL, so it's protected by 2 strong tendons. But the difficult thing about this interval is you're actually fighting a very strong tendon, which is the tib post, and therefore it doesn't give you access to it only gives you access to this bit, and maybe after you push that tendon slightly laterally, you get access to maybe to this side of the tibia. But definitely, if you do, like I do sometimes, if you have a posterolateral fragment and a posteromedial fragment and you want to fix it all through posteromedial, then definitely don't go through this interval. So go through the interval between the tib post and the flexor digitorum longus. So still your bundle is protected because the bundle lies between the flexor digitorum longus and the FHL. So still your bundle is protected and gives you much better access to almost the whole posteromedial. And if you're careful with your dissection and you have blunt instruments which you can carefully put subperiosteally on the lateral border of the tibia, then you have access to the entire back of the tibia on a very easily fixed posterolateral and posteromedial fragments through a posteromedial approach. And you don't actually believe it. So whenever I tell someone who's not very familiar with the approach, believe me, you'll be able to fix a posterolateral fragment from a posteromedial approach. They don't believe it until they actually see it. But it's much more extensile approach than the posterolateral. You can never reach a posteromedial fragment, or it's very difficult to do it from a posterolateral approach, but you can easily do it from a posteromedial approach. This is fresh off the boat, like they say. So it's published in a very prestigious journal, Injury, in 2022. Whether the plates or screws, are they equal in terms of the outcome, in terms of the rigidity of the fixation, in terms of the backing out of the metalwork, and definitely the plates, whether it's in a buttress mode or an anti-glide mode, it has a slightly superior outcome compared to the screw fixation. So I almost always, unless it's a very small fragment, I almost always go for a plate. A few things to note. If you see a posterior malleolus on an X-ray, please get a CT scan. As much as the resources are limited and everything, but you're really compromising the patient's treatment and management if you don't get a CT scan. And I'll show you in this. I have only one case, so you guys are not too bored, but I'll show you how important CT scan is. And remember, fixing the posterior malleolus, yes, it helps with the syndesmotic instability, but it does not mean that if you fix the posterior malleolus, you don't have any syndesmotic instability. So whatever test you use for anterior instability, whether it will be the hook test or the push and pull test or the external rotation test or whichever, or the tap test, whichever test is your favorite test, each one of them has pros and cons. So whichever your go-to test you use for the anterior instability, remember to check this after you fixed your posterior malleolus. I'm not sure if these plates are available in Egypt now. So now people are starting to think about, like we do with the distal radius, we do fracture specific or fragment specific plates. So we have some companies now which do a posteromedial plate, which is perfectly contoured and low profile for the posteromedial fragment, and a posterolateral plate rather than the T or the distal radius plate, which is sometimes used. And obviously the distal fibular anatomical plate now comes in 2 forms in almost all the companies, either a posterior, which you put on the posterior aspect of the tibia, or a lateral, the distal anatomical, the normal standard distal anatomical fibular plate. So if I get these x-rays, yes, I know the posterior fragments, yes, I know there is a fibular fracture, yes, I know there is a medial malleolus, a vertical tear, but unless I actually get CT, and unfortunately, and I do apologize, I tried to get the CT, but because the way we were allowed to take images from the hospital, I couldn't. So essentially what the CT showed is that there are posterolateral fragments, and there's a posteromedial fragment, and there's a separate anteromedial vertical medial malleolus fragment, as well as so some people refer to these ankle fractures now as quad malleolar, because the posterior malleolus is actually 2 fragments. So what I've done is I'll just walk you through these steps. So I did the posteromedial approach. I almost always start with the posterior fragment, because I want to be able to see absolutely that I've reduced this fragment. I get a perfect joint congruency, because if you didn't do that, part of the operation is not complete. And if you start putting a plate in the fibula, then the fibula will obscure actually your reduction. You won't be able to assess whether you've reduced this posterior fragment or not. The only exception to this is sometimes I fixed, if it's a 2-week or a 3-week old fracture, which unfortunately sometimes we have to deal with, sometimes we fix the fibula first. And the reason is because when you restore the length of the fibula, and we know that the PITFL is intact, the posterior fragment is not intact, but the PITFL is intact. So by reducing the fibula, you're helping with the indirect reduction of that posterior malleolus, because you're restoring the anatomy between the distal fibula and the distal tibia. So I've started with this plate, and I went for plate rather than screws, and sort of very rigid fixation. I start with the screw at the axilla first to buttress the fragment in place. I hold it with a wire first, and then put the plate on top of the wire. And because of the vertical medial malleolus, so vertical medial malleolus, we can't leave it, so we have to treat it, because it has a very strong shear forces across the fracture side. So the vertical medial malleolus, so I used the posteromedial approach, and I used the interval between the tip post and the FHL and the FTL, sorry, to get to the back of the tibia, to fix the tibia and put it back in place. And then I went to the anterior to the tip post, like I'm doing a medial malleolus, the standard medial malleolus, and I fixed the medial fragment. And again, made sure that this is congruent, so the joint doesn't have any articular steps. With my posterior plate, I forgot to mention, when I did it, I specifically used this plate. And the reason is because I knew it's a posterolateral fragment and a posteromedial fragment, so I tried to have only one plate and to put the screws in this particular position, so I can catch the posterolateral fragment and I can catch the posteromedial fragment. And then after I've done that, you can see that the fibula, you can hardly see the fraction. I promise you there was a fraction in the fibula, but because these ones are reduced well enough, now the fibular fracture is reduced into a perfect position that you can't almost see it. And then I put the fibular plate, I assessed the syndesmosis, and because you can't see it, but this patient had a very small fragment, which we call the Wagstaff fragment, which is essentially a fibular avulsion of the AITFL, and obviously it shows on the CT scan. So I knew that his AITFL as well is compromised. So I went on and fixed his fibula with the distal anatomical after putting an interfrag screw. And so imagine how, only judging by X-ray, how could I have known that this patient has a posteromedial fragment, a posterolateral fragment, a Wagstaff fragment. So the X-rays might have looked very benign, but the CT is a completely different story. And either you just ignore the posterior malleolus and you just say, I'm not fixing the posterior malleolus and I'm opposed to the idea, and that's fine. You're entitled to your beliefs. But if you want to fix the posterior malleolus, don't go at the back without knowing actually what you're about to expect, because you will not see it. You can fix it like 2 weeks or 3 weeks down the line. Everything will be, it will not be a fresh fractures. The fragment might have even sort of started to heal together. So unless you actually know what you're dealing with, it's just a bit of a gamble to go at the back. Thank you very much.
Thank you so much, Mr. Ahmed Al-Maghrabi, for this very interesting talk, and hoping to see you and Mr. Hussein, Dr. Rami, Mr. Ibrahim, and all our colleagues in States, Canada, Ireland, the UK, of course, and Germany in the upcoming Egyptian overseas online course. Hoping to see you, sir.
Thank you very much. Thank you, Professor.
Thank you so much. Thank you so much. Our last speaker in this session will be my dear friend and my brother, Mr. Brahim Said Qamar from Sligo University Hospital, Ireland. I'm very happy to see you.
Thank you, Professor Asha, for this generous invitation. I'll start sharing the. I know it's too late.
No. We have another 3 hours in the lower limb trauma session.
So, sorry for this. So today, our talk will be about the subtalar dislocation. So, the objectives of this presentation will be to discuss the mechanism of injury and the types of subtalar dislocations and the different management approach and the prognosis of this injury, and we'll give just a case example of this. So the subtalar dislocation is not a common dislocation we can see. It is a rare event. It is less than 1% of all dislocation, less than 1 per 100,000 per year. It is more common in the young or middle-aged males. It is usually, or most of cases, resulted from a high energy mechanism, and some literature saying 25% may be open, and some papers saying it up to 40%. Lateral dislocation is more likely to be open up to 60% of cases. So there is associated dislocation, like talonavicular joint dislocation, one of the common associated dislocation with the subtalar dislocation, and the associated fracture up to 44% of cases. With the medial dislocation, the dorsomedial talar head, the posterior process of the talus and the navicular bone. With the lateral dislocation, the cuboid and anterocalcaneus lateral process of talus and fibula is more common to be seen. The types, this is the anatomical classification. This is based on the dislocation of the midfoot over in relation to forefoot, and this is based by Broca in 1853, about 170 years ago. So the most common is the medial dislocation. This is about 65 to 80% of the cases, resulted from the inversion force on plantar flexed foot. The substiculum tali act as like a fulcrum to rotate the neck of talus, will rotate and pivot around it and dislocate it. Usually, when we have medial dislocation, the reduction will be blocked by lateral structures like the peroneal tendons, extensor digitorum brevis muscle, talonavicular joint capsule buttonholing can happen and block the reduction. In the lateral dislocation, it is more likely to be open, as we mentioned. It is resulted from the eversion of plantar flexed foot. So the reduction, as we mentioned, will be blocked by the medial structure like the posterior tibial tendon, the FHL and the FDL. There is the posterior dislocation, which is rare. It's 2% of subtalar dislocations. It will happen with plantar hyperflexion. Will be tearing of the interosseous ligament, and the talar head will be sliding over the navicular. So when we see in the lateral X-ray, we can see the talar head is higher than the navicular bone. It is highly unstable, and most of the time it converted to medial dislocation. The anterior dislocation is very rare, it's less than 1%. It is excessive dorsiflexion with or traction force. The very high unstable converted mostly to lateral dislocation. Management approach, as we dealing with high energy trauma, so we are not treating only the fracture or the dislocation, so we need to treat the patient himself. So we need to follow the ATLS protocol first and be sure that we treating all the life-threatening condition before this. But to addressing the assessing the patient and the physical exam, we need to assess the neurovascular status of the limb, the soft tissue, seeing if this open or closed injury, and we can see in the physical exam, in the medial dislocation to be locked like the foot would be locked in supination, which is known as acquired clubfoot. In the lateral dislocation, looks like acquired flat foot and locked in pronation. So the imaging, the main thing the X-rays, and as we mentioned, the medial dislocation tiller head will be superior to navicular bone in the lateral view, but in the lateral dislocation, the tiller head will be collinear with the navicular or inferior to it. CT scan is to assess any associated fractures or debris inside the joint, and usually we do the CT scan after performing the reduction, nothing to delay the reduction of the dislocation. So it can be done non-operative. About 60 to 70% of dislocation can be reduced in closed maneuver. Usually we need to flex the hip and the knee to ease the traction from the gastrocnemius, and then counterflex the foot, and then we can do eversion or inversion according to the direction of the dislocation. Most of this dislocation will be stable and can be bought in a blue knee cast for 4 to 6 weeks with non-weight bearing. If there is the reduction is blocked, then we need to go for open reduction, and this is indicated in the open dislocations, failure of closed reduction. About 32% of cases required to go for open reduction. As we said, middle dislocation blocked by lateral structure like peroneal tendons, the extensor digitorum brevis, and lateral dislocation like in this image, the posterior tibialis tendon, flexor hallucis longus, and flexor digitorum longus. When we go to reduce medial dislocation with the open technique, we need to go for sinus terci incision to clear the debris and to clear the blocking structure in the lateral aspect. You can go for medial incision for the lateral dislocation, but also sometimes we need to make another incision laterally to clear the joint. The complication of the subtalar dislocation, the most common complication is the stiffness and the post-traumatic arthritis. It is like most of patients, we can see radiographic evidence of arthritis in long term, about 89%, but only 63% will be symptomatic. A vascular necrosis of talus can be happen, especially if the dislocation associated with fracture of the talus. The prognosis will be very poor with the high energy mechanism and as the lateral dislocation, which is mostly higher energy needed, and also for the open dislocation because the wound complication and the infection. This case came to our hospital. She is 83 years old female. She was a driver and she hit a wall. So she attended to the ED, which the guys in ED followed the ATLS protocol, the take image. They tried to reduce it first, but they couldn't. And they called us to come to give them hand there. They give sedation in the ED, and we already reduced the dislocation in the ED. And we followed the British Orthopedic Association standard number 4 regarding the open fractures, like starting antibiotic, applying saline-soaked gauze, and the tetanus vaccine and the other guidelines. Then we took the patient to theaters, and we did X-fix, and we did the debridement for the wound, and we applied the VAC dressing. This is the image from theater after applying the X-fix. And then we sent patient for CT scan, which showing the posterior process of the talus was broken, and there's some debris also in the joint. So we took the patient again for another session of washout, debridement, and we go with the minimal incision, like small incision posteromedially. We go between the Achilles tendon and the flexor hallucis longus, and we used a 4mm cannulated screw to fix this fragment. We kept the X-fix for 6 weeks for the care of the wound and to keep the stability of the joint. After that, we removed the X-fix, wound is healed. The patient started weight bearing, accelerated a range of movement exercise with physiotherapy, and the patient doing well after that. There is some papers I'd like to be good evidence. And thank you, Belbolben Mountain from Sligo. Thank you.
Thank you so much, my dear brother, Dr. Ibrahim Said Kamar, for this very interesting presentation about a very interesting topic. Thank you so much.
Thank you. Thank you. Have a nice day. Thank you.
I think it's too late for you.
I like for me because I had not 9:30. I'm waiting for Isha prayer and then sleep.
Hoping to see you soon.
Inshallah.
Thank you so much,
Thank
my
you, thank
brother.
you, thank you, Professor Ashraf. Thank you, thank you.
شكرا جزيلا أخي الحبيب. We have finished now the session UK experience in trauma.